the end result can be a full ARDS. Transfusions, pancreatitis, some gynecologic causes like preeclampsia or an abrupto placenta. If your placenta is separated from your uterine wall, or you develop this very, very elevated blood pressure during pregnancy. These things have been known to cause ARDS. You can have drug effects where you're reacting to drugs that you've taken, or a sickle cell crisis can even cause rapid and sort of a full-blown inflammatory response to not just the joints and places where the cells get clumped up, but in the lungs as well. So now, how much ARDS do we have? Well, I guess these numbers will be changed with a little asterisk for 2020. But roughly 200,000 cases in the whole in the country for a year, and typically in a large medical center, it only accounts for 16% of the mechanically ventilated patients that admit to the ICU. And I had mentioned this the other day, is that you might go a whole semester, and hopefully you will, where you won't see a patient with ARDS. So as terrible as this outbreak is, when you do return to clinic, you should, ask some questions about the patients and how they're taking care of them, and how it came about that they, recovered, and what worked and what didn't. Things to keep in the back of your mind for later on when you see a patient that develops ARDS during your career, and you're the respiratory therapist standing there in the ICU. So the estimates are that they've spent approximately 2 million days, they account for, in the ICU, and about 4 million days in the hospital. And they estimate that the cost measured is in the billions of dollars. They're very expensive patients to take care of. They require all of the resources in the hospital to take care of them. The burden can't even be explained that they're going through now in these big medical centers, because these are expensive patients to begin with, and to have it in the thousands is just, oh my God, horrendous. They're going to use, all of the support that you have. In other words, it's going to definitely take a whole team to take care of these patients. And there's no exact treatment. There's only things that you can do to try to support the patient until the lungs are able to heal. And that is really the goal. And so if you can find the cause, and it's a definitive cause, such as what we're seeing now, the COVID-19, and if you can treat the cause, unfortunately, that we haven't been able to do that yet. So that's why things like vaccines are so important. The flu vaccine, to stop you from getting a pneumonia from the flu that can develop into ARDS, just like that. And that's why older people take the pneumonia vaccine, because if they get pneumonia and they cannot fight it, it's going to be ARDS. And it's something that has a very high mortality rate. they may not come out of it. And so when we develop this vaccine, it's going to be really key in the treatment of this form of ARDS. So the treatment would be prevention. And now from the other standpoint, you've got to support all of the other organs too. So not only do you have to desperately try to get oxygen into the patient, you've got to do it so that all the organs can stay going. You got to get oxygen to these people's brains, right? And also you want to minimize their delirium. They have, we've seen it on TV where the workers say the patients are scared. So they've got to treat that anxiety and pain. And try to promote the awareness of the patient, keep their ability to interact as much as possible, and keep them oriented to day and date, time, that kind of thing. Keep their mental acuity sharp, because the drugs that we use to support the patient's mental state can have long-term effects on the patient. So if, for instance, the patient is given lorazepam or midazolam, so like Versed, right? So you think, oh, that's good, because he won't remember anything in his ICU stay. That's all well and good, except for it may actually affect his memory after the fact too. So these medications do have side effects. And so now we're going to support his lung function. So how are we going to do that? Well, PEEP, basically. You know about PEEP? We talked about, and you used PEP valves. Remember when you blew into the PEP valve and you felt that pressure in your lungs? Well, let's think about what's going on here. We've got fluid coming into our lungs. So let's push it back to where it came from. That's all. Just push it back. Let's see if we can push it back. And how are we going to do that? With some pressure. Okay. And so when we inhale, the lungs are opening, the alveoli are opening. When we exhale, that's when the alveoli tend to collapse, right? So here is PEEP, positive end expiratory pressure. So that means that during the expiratory phase, we're going to keep pressure on your lungs so that those alveoli don't collapse. And this helps with oxygenation. But the added pressure in your chest, it changes the whole dynamic in there. Remember, you have to create that negative pressure when you breathe in, and then it becomes a little more positive. Well, hey, if you start adding pressure into the alveoli, then you decrease the body's ability to bring blood into the heart, right? That's called a decreased venous return. So if you're putting positive pressure in the chest, you're like pushing back the blood, right? Just think about it. Think about the blood coming back from your legs, and it's trying to get into your chest so it can get into your heart. And all of a sudden you put all this pressure, positive pressure inside somebody's chest. Well, the blood can't get in, right? That's what's happening. So you can reach a point where we can only give so much pressure into the chest. So it's a great idea and it works, but you've got to keep an eye on the patient's blood pressure because we're stopping the flow of blood into the heart every time we get to high levels that are required to keep the oxygen in these patients with ARDS. Okay, so what else are we going to do? So we know PEEP, okay? And I believe that you understand PEEP. If you don't understand PEEP, then you need to let me know when we do our face-to-face on Thursday. And we'll go into it a little more. what are we going to do about this fluid balance on the patient? Well, they have decided that the best thing to do is to not overload them with fluids. Okay, see the word conservative? That you want to remember that word. We're going to have conservative fluid management. Okay, so that means, what does it mean? It means that we're going to not overload them with fluid. We're going to be very careful. We're going to be very careful. Sorry about that. Guess I got to plug in my computer. I thought it was. Okay. So we have to be very careful with the fluid that the patient gets, and we have to maintain a good blood pressure. That's what this is all about here. Maintaining perfusion pressure means that we have to maintain enough blood pressure so that the blood is able to get to our vital organs. Okay? So we've got to have enough pressure to get blood to the brain, the heart, the kidneys. All of our vital organs have got to be have blood flow with oxygen. And hey, the oxygen is going to be a hard enough thing. So the blood flow has got to be there because the oxygen is going to be difficult to get. So the other thing that we're going to do is prevent further lung injury. If we're constantly giving injury to the lungs cannot heal. That's the bottom line. And so I realize that we haven't talked about mechanical ventilation, but I highlighted these two things in red here because I think you can appreciate these even without an understanding of mechanical ventilation. But remember, barotrauma. Baro means pressure, like your barometric pressure outside. Okay, so the pressure that we want to put on the lungs, right? Because we talked about that, PEEP. We want that positive pressure on the lungs because it helps us get oxygen and push that fluid out. Every time that we increase it, we're causing barotrauma. So we want to avoid too much barotrauma. And volutrauma. Guess what volutrauma is? Volutrauma is too much volume. So too much volume, trying to push too much volume into these stiff lungs causes trauma. And I believe that you can accept that. That too much pressure or too much volume, it's just a matter of time before you have to absolutely know this like the back of your hand anyway. So you might as well pick it up now. So I'm thinking that you can remember avoiding barotrauma and volutrauma. And the other thing I'd like for you to pick up and remember, you might as well remember it now, is the tidal volume. Now remember, tidal volume is just the amount of air that you breathe in a normal breath, right? So that's all we're trying to do for these people. We're just trying to breathe for them. Is that right? Because they can't do it themselves. So we're breathing for them. So normally when you and I breathe, we breathe about, let's say, 6 to 10 mLs per kilo. Probably closer to 7 and 8. Well, if we give them a normal breath like that, it's just going to take too much pressure to get it in. Their lungs are stiff. The alveoli are stiff. Too stiff. So they have set up, and I sent it to you, the Ards protocol. And that was based on very many studies that came together, and they grouped it together, and they said, hey, we're going to have to come out with a clear-cut way to treat these patients. And they came up with the best way to have survival in this patient population is if you give these small tidal volumes of 4 to 6 mLs per kilo. And you might as well remember that now, because you're going to have to memorize it and know it for the rest of your life anyway. So